endosono, diagnostic endosono. I'm seeing the posterior aorta, and I can also see the anteriorly the liver. So you can start the interrogation of obstructive jaundice at G junction, So I'm seeing this aorta and the celiac take off, and then I push the scope and I can see the pancreas over there. So this is the pancreas, which is hypoechoic, and I can see a duct there within that, and the duct is not uniformly dilated. You can see as I'm rotating towards the pancreatic tail, as I'm crossing the left kidney, going towards the spleen, I can see a sausage type of pancreas. You can see this is a pancreas which is diffusely bulky, and I cannot see any duct inside, and the duct is very, very thin. So the duct, I can see here that if I measure the duct at one place like this, this is the duct.
Can you use the cursor, please?
Yeah, of course. I'll do that.
This pointer.
So now, yeah, you can freeze, please.
Freeze.
Yeah. So now we can see here, this is the duct, and this is the whole pancreas, which is diffusely enlarged, and I can see the duct here, which is not very dilated. The duct is around 1.9 millimeter in the pancreatic neck area, but as I am going towards the tail, the duct is getting narrow, and also sometimes the duct again getting appeared. Here you can see the duct is again appearing.
Are those calcification, Dr. Mohan, recent calcification in the parenchyma?
There are no calcification, and I'm just concentrating on the duct morphology, because in a case of obstructive jaundice, if you have a pancreatic head pathology, you will have a diffuse ductal dilatation in case of malignancy. But here I am seeing a pattern where the pancreas is a sausage-shaped pancreas. You can see I can see from here, from the spleen, you can see that the pancreas is diffusely enlarged, and it looks like a sausage. And the duct is not uniformly dilated. It is dilated at some place and then getting narrow. So this brings to my mind that whether I'm dealing with an autoimmune pancreatitis. In autoimmune pancreatitis, the parenchyma is diffusely enlarged. The duct is sclerosed, not dilated because of one focal lesion. So in this case, we saw that. And autoimmune pancreatitis also involves other organs like the bile duct, or there can be lymph nodes, or there can be renal lesions, or there can be a thyroid or mandibular lesion. So let's see what is happening to the bile duct. So I go anteriorly now. From the posterior, I'm torquing my scope to the anterior, and then anteriorly I'm seeing the hilum. So this is the hilum. You can see this is the liver. So this is the. Can I have the pointer here? Yeah. So this is the liver, and portal vein is coming from below upwards to the liver. And as I rotate, I can see the bile duct. That is the bile duct, which has got a stent inside.
Thickened.
Yeah, see that? That's the bile duct. Can you freeze, please? Freeze, yeah. Yeah, 1 minute. I'll just show the thickened bile duct. You can see the bile duct is very thickened. And then there is no ductal dilatation intrahepatically. See that? That's the sclerosing variety of changes there. You can see now. Here you can see the duct is so dilated, the bile duct thickened, and then there is a very thin intrahepatic duct. There is no intrahepatic biliary ductal dilatation. So in this case, we are finding a sausage-shaped pancreas, non-dilated duct, thickened bile duct with a sclerosing pattern intrahepatically. So this is an IgG4 related disease, which we can also, this is only diagnosed at G junction. We have yet not gone into the duodenum. So So when
We-
you come
we-
back, we'll explain more.
We always hear a report from the
You can see there's a bile duct there, which is filled with stent, and I can see a pancreas. You can see here, there is no focal mass. Whole of the pancreas is hypoechoic, diffusely enlarged. And then when we see the bile duct, you can see the bile duct is narrow at the lower end within the pancreas. And as we are coming up towards the
Dilated.
to the hepatic hilum, we can see a very thick wall CBD there.
So,
No, I think it should be all in the clinical context. This patient, a young female with no comorbidities, no weight loss, has presented to us with obstructive jaundice. We must go into the depth. Why? What is the cause of jaundice? Is it cancer pancreas? Answer is no. Pancreas is diffusely enlarged, duct is not dilated. The autoimmune disorder, that is IgG4 disease, has also involved the bile duct, causing its thickening, and there is a very much thickening or dilatation in middle. But as we come to the intrahepatic part, there is no intrahepatic ductal dilatation. So this is a sclerosing variety of cholangitis affecting the bile duct and also the pancreatic duct, very classical of autoimmune.
So Mohan,
Go into the depth of that biopsy, what are the other features, because we must see for obliterative phlebitis, we must see for storiform fibrosis, which pathologists may not be well versed. They will say, okay, negative or positive. But if you must go into the depth of that core biopsy, whatever been taken, and also serum IgG4, and also once you have a classical picture with other organ involvement, with high serology, it's a
We will start treatment.
Start the treatment and see the response.
Mohan, I have a question. Is elastography...
Any other queries, or do you agree with me, or you have other, should we do the biopsy? Should we do a contrast enhanced EUS? What are the opinions from the
Floor.
From the floor?
There's a question first, Mohan, Dr.
I
Mohammed.
think
Yeah.
the mic is not working. I wanted to ask about elastography for follow-up.
So we have a question here. What is the role of elastography for follow-up of those cases?
I will not go, there are no much data on that, elastography, but we always see the imaging, whether there is a reduction in the sausage-shaped pancreas. We also go and remove the CBD stent and see whether there is a resolution of the stricture. These are the things, but follow-up elastography, I don't think there is a much data on that to compare before and after and plan the treatment, because this is more of edematous pancreas.
Dr. Mohan, if you decide that this is autoimmune cholangitis or IgG4 cholangiopathy, what is your protocol of steroids? How much you give, for how long, and how do you taper it?
Yeah, so very good question. And also what we do is, there are two mode of therapies available, the steroids followed by azathioprine, or you can start with rituximab. So the rituximab is also very good. So at present in our institute, rituximab is a drug which we save once there is a recurrence of steroids. So we start with 1 milligram per kg prednisolone continuously for 1 month, and then start tapering every 2 weekly by 10 milligrams. So at least 2 to 3 months of steroid, and once the steroids are over, we shift them to azathioprine for long term. Our recurrence rate is very high. If you start a shot of steroid and stop the steroid, the recurrence rates are very high. But some people won't respond, and if you have a very strong diagnosis in a young female with such, you must think about rituximab. But if you do not have a strong diagnosis, then you should revisit the diagnosis at 2 months, whether I am missing a cancer pancreas, because there can be a not diffuse enlargement, there can be a focal mass, which we are thinking autoimmune. So one must be a very cautious approach that at 2 months you must document the reversibility of the imaging. Otherwise, you must think about alternative diagnosis or surgery.